I have a request for you to start off, and that request is, later on in this talk, I am going to be moving from website to website, and I have been told if there are a lot of computers online, it may not work. So if you could either close your computer or take it offline, that would be very helpful. So I'm going to start off by how I define evidence-based medicine with 3 key principles. I'm going to use a historical approach and introduce you to many of the key figures who have been played a part in the development of evidence-based medicine. I'm then going to talk about its evolution and evidence-based medicine in the time of COVID. This is Dave Sackett. Dave Sackett was the founding chair of my department at McMaster and was my mentor and the mentors to many leaders within evidence-based medicine. And one of David's major contributions, he made many, was to define the first hierarchy of evidence. And in this hierarchy of evidence, we recognize that our personal clinical experience is a legitimate source of evidence, but it is limited by the subjective nature. Basic research can contribute, but difficult to apply. Observational studies may be plagued by bias, and so randomized trials are at the top of this hierarchy. This is a very simple hierarchy, and we have since advanced, and our current hierarchy, which I'm going to introduce to you later in this talk, is much more sophisticated than this one. This next gentleman that I'd like you to introduce is Ian Chalmers. Ian Chalmers is the individual most responsible for setting up and creating the Cochrane collaboration. Who in this room knows what the Cochrane collaboration is? Hands up. Who knows what the Cochrane collaboration is? I'm going to be asking you questions. Some people do and some people don't. The Cochrane collaboration has set its goal of summarizing all the randomized trials of therapy, of interventions known to humankind. And it's well on its way to achieving that through systematic reviews of these therapies, over 10,000 of these currently in the Cochrane collaboration. How many people in the audience are familiar with plots like this, which are called forest plots? Who knows about these? Okay, lots of people, good. So this is a forest plot about thrombolytic therapy in patients who have undergone a myocardial infarction. And it is a different sort of forest plot than you're used to. If you look at the top of the screen at the first trial of thrombolytic therapy, it enrolled only 23 patients and had a very wide confidence interval. The second trial enrolled not 65 patients. This is a cumulative meta-analysis, only 42 patients in the second trial for a total of 65. Now, if you look down, by 7 trials and less than 2,000 patients, our confidence interval still crosses no effect. But by 10 trials and 2,500 patients, the confidence interval no longer crosses no effect. Well, we could discuss when the answer to the effect of thrombolytic therapy was in, but if you look by 30 trials and over 6,000 patients, the confidence interval is now a long way from no effect, and we have a very low p-value, establishing a 25% reduction in the odds of dying with thrombolytic therapy. Did this stop the trialists from continuing to do trials of thrombolytic therapy? No, it did not, and the reason it did not is on the right side of this slide. But before we get there, consider another 40,000 patients needed to be enrolled or were enrolled after the answer was in. half of whom did not receive the life-prolonging benefits of thrombolytic therapy. So why is it that we needed to enroll another 40,000 patients after the answer was in? Well, I'd like to suggest that a big part of it is on the right side of this screen, which is textbook and current review recommendations that were appearing as this evidence became available. And what you see, first of all, is sometimes the experts are recommending to give it routinely, sometimes for specific indications, sometimes calling it experimental, and sometimes not mentioning it. And if you look at the latter part of the 1980s, you have wide expert disagreement. Some saying it's routine, some not mentioning it. And it was a decade after the answer was in that finally you have a consensus among the experts, and that's why the trialists had to continue doing trials. The next story I would like to tell you is one that dates back when I was training as a resident 45 years ago, and I did a rotation through the coronary care unit. Well, every patient that came through the door, I started what we called a lidocaine drip, a prophylactic doses of intravenous lidocaine. And why did I do this? Well, I did this because my attending suggested that this would help the patients. Was there ever any evidence from randomized trials that it did help the patients? No. In this case, all the point estimates were on the harm side. Increased deaths with lidocaine. Did this stop the experts from recommending it? No. Most of the experts over the 20 years that these data accumulated were recommending prophylactic lidocaine, although once again, you have wide expert disagreement. So we've got big problems. We've got experts a decade behind the evidence. We've got experts making recommendations, lots of them, that are inconsistent with the evidence. Now, these are old stories. They ended in about 1990. Since 1990, experts still disagree and they still make mistakes, but perhaps not so badly as this. Something has changed. Something changed in 1990 that made it less likely for this big expert disagreement and mistakes, and that was the introduction of systematic reviews. It was in 1990 vicinity that systematic reviews and meta-analysis started to appear in the medical literature, and I would suggest that if the experts had had systematic reviews and meta-analysis of thrombolytic therapy and lidocaine, they would not have gone so terribly wrong. So, we have the next individual I'd like to introduce you to is Brian Haynes. And Brian Haynes was a chair of my department for a decade. And his contribution, or one of his contributions, was about physicians' and patients' choices in evidence-based medicine. And in an article published about 20 years ago in the BMJ, he said, "Evidence does not make decisions, people do." Well, what was he getting at? P.J. Devereux, who works at our institution and is changing the world in terms of perioperative medicine, a while ago did a survey of patients and clinicians. And I would like you to pay close attention because I'm going to repeat P.J.'s experiment in a minute and ask you to take the role of participants. So consider the following. Without treatment, 100 patients with atrial fibrillation will suffer 12 strokes, 6 major and 6 minor. Anticoagulation would decrease strokes in 100 patients to 4, 8 fewer strokes, 4 major and 4 minor. And the question is, how many bleeds, serious gastrointestinal bleeds, would you accept in 100 patients and still be willing to administer as the clinician or use as the patient anticoagulants? Well, Dr. Devereux enrolled about 60 patients and 60 clinicians, and of course, he had to make sure the patients understood what it meant to have a stroke and what it meant to have a bleed. And here is his description of minor strokes and major strokes, which when I show this to people, they usually think these are reasonable. And here is his description that he gave to patients of a serious gastrointestinal bleed, which again, people seem to think is a reasonable description. So now I'm going to, in a moment, be asking you the question of what your view is on this. So again, without treatment, 100 patients will suffer 12 strokes, 6 major and 6 minor. Anticoagulation will decrease strokes in 100 patients from 12 to 4. 8 fewer strokes in 100 patients. It prevents 4 major strokes and it prevents 4 minor strokes. And how many serious bleeds would you accept in 100 patients and still be willing to administer or take anticoagulants? Mortality, any mortality with strokes balances with bleeds, so you're trading off strokes and bleeds, not deaths. Okay, hope you understand the question. So, to prevent 8 strokes, how many of you would be ready to accept 5 or fewer bleeds? In other words, if there were more than 5 bleeds, no anticoagulants. How many 5 or fewer bleeds? Hands up. Anybody 5 or fewer bleeds? You people. How many would be ready to accept 6 to 10 bleeds? No more than 10, but 6 to 10. Okay? 11 to 15. How many would accept 11 to 15? Okay, there's some people. How many 16 or more? How many would be ready to accept 16 or more? Some people. Okay, here's the first conclusion. We had people in each of those categories. Some said less than 5, some said 6 to 10, some said less 11 to 15, some said over 15. What are these differences all about? Why do you have such differences, and what do we call them? We call these values and preferences. Some people in this audience are very stroke averse, and some people are very bleeding averse. These are different values and preferences. And here's what happened when Dr. Devereux asked this question to 60 clinicians and to 60 patients approximately. The clinicians, you see, have a very flat distribution, just like the distribution we saw in this room. Some less than 5, some 6 to 10, and so on. I've reproduced Dr. Devereux's experiment in many internal medicine audiences like this, and Dr. Devereux's results are very replicable. But look at the patients. 2/3 of the patients are ready to accept 22 bleeds to prevent 8 strokes. Why 22 seems like an odd number. When Dr. Devereux organized his survey, he was thinking like a clinician and not like a patient. He thought they wouldn't take more than 22 bleeds. They would have if he had given them the opportunity. So, patients are much more stroke averse than the clinicians. That's the first big message here. Clinicians are variable in their preferences, in their aversion to strokes and bleeds, but patients are almost uniformly or very largely stroke averse. So, first message, if we are to take our values and preferences and apply them to our patients, the patients may not get what they would want if we take their values and preferences into consideration. First message. Second message, although it's much better to take average values and preferences, and the average values and preferences are the patients are much more stroke averse than the clinicians, but there are a few patients at the other end. There are a few patients who have the same values and preferences as the clinicians. They are more bleeding averse. So if we really want to get it right, we have to take into account the individual patient values and preferences. So I have now reviewed what I think are the 3 key principles of evidence-based medicine. 1, Some evidence is more trustworthy than others, and EBM provides clear guidance as to most trustworthy available. In a little while, I'm going to tell you about the latest guidance from evidence-based medicine about the relative trustworthiness of different types of evidence. Second, the best clinical care requires systematic summaries of the best available evidence. I've shown you some examples of how terribly wrong experts had with their recommendations in the absence of such reviews. And finally, an ironic principle perhaps, evidence is never by itself sufficient. Decisions always require consideration of patient values and preferences. So, the next individual I'd like to introduce you is a guy named Andy Oxman. Andy Oxman spent a decade or so with us at McMaster before moving to Norway, where he now resides. And Andy is responsible for a huge, or getting started anyway, a huge advance in evidence-based medicine. And if you go back to the year 2000, people were providing, guideline panels were making recommendations all over the place. They were making comments about the quality of the evidence and the strength of recommendations, but they were extremely variable. The systems were not well thought out, and it was chaos. So Andy's idea was, could we make a system of rating our confidence or certainty in the evidence from systematic reviews and from moving from evidence to recommendations that would be so compelling that it would be very widely adopted? And that was the challenge that Andy set himself and a group of us. And we created a system, first published in the BMJ in 2004, that is called GRADE. So, as I say, first published in 2004. In 2008, a 6-part series in the BMJ for clinician users. 2011 to the present, a whole series of articles in a methods journal for systematic reviewers and guideline developers about how to use GRADE. Well, it's been very successful. I would say it's been successful beyond our wildest dreams when we got started. Over 110 organizations worldwide have adopted GRADE. They include the Cochrane Collaboration. They include the World Health Organization. They include major American organizations like the American Thoracic Society and the American College of Physicians. And how many people in this room use UpToDate? How many people use UpToDate? Okay, lots of people use UpToDate. UpToDate has over 10,000 graded recommendations, and I would argue the most important organization to adopt GRADE is UpToDate. So, how does the system work? One part of the system is to rate the certainty or quality or confidence in the evidence. Those are all synonyms: certainty, quality, or confidence. And there are 4 categories of certainty of evidence: high, moderate, low, and very low. And randomized trials start as high certainty evidence. Observational studies start as low certainty evidence. But randomized trials may not end off as high certainty evidence. Why not? The randomized trials may be unconcealed, unblinded, and lose lots of patients to follow-up. Risk of bias. They may be inconsistent in their results, and we may be unable to explain that inconsistency. I'll tell you what I mean by indirectness of the evidence. How many people in this room practice general internal medicine? Hands up. Lots and lots. How many practice geriatrics? Hands up. A few. How many people who practice internal medicine sometimes feel like they're practicing geriatrics? Okay, lots. Okay. In my setting, If I go back 20 years, I saw very few people over 90. I practice as a hospital-based internist. Now I see lots of people in my practice over 90 and lots of people over 80. Now, I try to practice consistent with the results of randomized trials, but those randomized trials included typically very few people over 80 and very few people over 90. Should I be hesitating about applying the results of these randomized trials to my patients over 90? Perhaps I should. Perhaps because the randomized trials of younger patients provide indirect evidence for my patients over 90. So that's what we mean by indirectness. The evidence doesn't quite fit with the patients that we have before us. Imprecision, small numbers of patients, small numbers of events, and as a result, very wide confidence intervals. And finally, everything else can be okay, and there can still be publication bias, particularly industry-funded trials where they hide the evidence from negative. So, randomized trials may start as high quality or certainty evidence, but with any of these 5 problems, they may go down to moderate, low, or even very low quality evidence. So much more sophisticated than randomized trials just at the top. Observational studies start as low. They can go to very low if they have these problems, but they can also move up. I would like to ask you to think for a moment of interventions that you do for which you are sure that they work, but there's no randomized trials. What do you do in your daily practice that you are sure works, even no randomized trials? I'll give you some examples in my practice. Cardiac resuscitation. When your heart stopped, you used to be dead. Now, some people are not dead. Dialysis in terminal renal failure. People with terminal renal failure all used to die. Now, with dialysis, we can give them a longer life. Sometimes not so much longer, but a longer life. Epinephrine and anaphylactic shock, insulin and diabetic ketoacidosis, furosemide in acute pulmonary edema. No randomized trials, but because of large or very large treatment effects, we are certain of their benefits to our patients. So again, much more sophisticated than the old hierarchy. Randomized trials start at the top, but can be rated down. Observational studies start low, but can be rated up. Here is the way GRADE likes to present the summaries of the evidence. And this is called a summary of findings table. It's a summary of findings table for baricitinib in patients with serious or critical COVID. And I'm going to take you through the first row. The first row is about the outcome of mortality, and the second column gives the relative effect, a 38% reduction in the odds with a confidence interval from 56 to 15%. The next columns focus on what's really important to patients, which is not relative effects, but absolute effects. And we have a 13% mortality in those who do not receive baricitinib and an 8.5% mortality in those who do, with confidence intervals from 68 to 17. The next column gives the certainty or quality of evidence in this high, moderate, low, or very low, considered moderate certainty evidence, and a plain language summary. Baricitinib probably reduces mortality. And you can see we can have summaries of the same sort for the other outcomes: mechanical ventilation, adverse effects, hospital length of stay. So that's the GRADE approach to the quality of evidence. We're now going to move to GRADE's approach of moving from evidence to recommendations. Recommendations can either be strong, where the benefits clearly outweigh the downsides, or the downsides clearly outweigh the benefits, or they can be weak or conditional. Those are synonyms, weak or conditional. If the balance between desirable and undesirable, I was told I have an hour to talk. I apologize. I was told, and I checked very recently, that I had an hour to talk, but it's now been changed. All right. Okay. So what'll I do in 2 minutes? Okay, in 2 minutes, I'll tell you about the strong versus weak recommendations, variability in patient preferences, strong recommendation, all or almost all fully informed patients would make the same choice. That means a strong recommendation does not necessitate a full shared decision-making. A weak recommendation does. And decision aids, there are more. I was going to show you some. There are more available, and they might not be needed in a strong recommendation, would in a conditional. So I'm going to then go right to the end, and right to the end, I am going to tell you a little institutional and self-promotion here. Here are our user's guide to the medical literature, which have the principles of EBM are now in every medical school and residency program, certainly in the United States and Canada, and maybe throughout North America. If you're interested if you tweet and are interested in the latest of what's going on in evidence-based medicine, you can follow me on Twitter. And if you are interested in attending the McMaster International Review course in evidence-based medicine in 2023, this is going to be in Krakow, Poland, a very different place from Hunakanta, but also a very interesting place to visit. Thanks very much.